Welcome to the e-learning module on inflammatory bowel disease. In this video, we'll learn about ulcerative lesions of intestine and differential diagnosis. The learning objectives are to enlist the differential diagnosis for ulcerative lesions of intestine and to differentiate these ulcerative lesions based on morphology. Ulcerated lesions can be classified as neoplastic lesions and non-neoplastic lesions. The common causes for non-neoplastic ulcerative lesions are inflammatory bowel disease, includes ulcerative colitis and Crohn's disease, vasculitis or some allergic disorders, infections are commonly tuberculosis, typhoid or amoebiasis, ischemic bowel disease, medications like NSAIDs and amyloidosis. Causes for neoplastic ulcers includes primary carcinoma or metastatic intestinal carcinoma, malignant lymphoma, or gastrointestinal stromal tumors. Whenever we are dealing with ulcerative lesions, we can do certain investigations using endoscopy, radiography like CT or MRI scan. You can take biopsy and also do serology for infections or some autoimmune disorders. Whenever we are assessing the ulcerative lesions, we have to assess the morphology of these lesions. The characteristics of ulcers which are helpful in differentiating these lesions are morphology. In morphology, we should assess whether the ulcer is circular, whether it is longitudinal or it is irregular. It is also important to know the size of the ulcer, distribution, which part of the intestine is affected, and whether the lesion is single or multiple, and also the depth of the lesion. So coming to common examples for ulcerative lesions, in India, the most important DD is tuberculoid ulcer. A grossly tuberculoid ulcer will be transverse, so it is seen along the short axis of the bowel. It is a transverse ulcer and seen along the direction of lymphatics. And on histopathology, you can see typical caseating epithelioid granuloma having central caseating necrosis, giant cells called as Langerhans type of giant cell, epithelioid cells, and rim of lymphocytes and also fibroblasts. So tuberculoid ulcer will show transverse ulcer. Whereas typhoid ulcers, they are usually oval. They are seen along the long axis of the bowel. They are oval ulcer. And on histopathology, you can see aggregates of macrophages giving rise to the nodules called as typhoid nodules. Next infective cause for ulcers are amoebic ulcer. Amoebic ulcers are usually multiple and they are undermined ulcers. And on histopathology, the typical morphology is flask-shaped ulcer. As you can see here, it is flask-shaped ulcer with broad base and narrow neck. And next differential diagnosis is inflammatory bowel disease consisting of ulcerative colitis and Crohn's disease. So in ulcerative colitis, the distribution is continuous. There is continuous affected area in the colon, and the ulcers will be wide, having broad base, and you can also see pseudo polyps. On microscopy, you can see superficial ulcer. The inflammation is seen only in mucosa and submucosa, and you can see aggregates of neutrophils in the lumen called as crypt abscess, and also crypts are infiltrated by neutrophils, which is called as cryptitis. So here the inflammation is involving only mucosa and submucosa, and there is continuous involvement of the affected bowel. Whereas in Crohn's disease, there is skip lesion. Skip lesion means there is alternate areas of lesion and there is no the alternate areas of affected lesions and not affected areas. And the ulcers here are longitudinal called as serpiginous ulcer, and the affected area will be depressed and the unaffected alternate areas will be edematous, leading to the appearance called as cobblestone appearance. And on microscopy, you can see transmural inflammation. Muscularis propria is also having inflammatory infiltrate, and you can see non-caseating or non-necrotizing sarcoid-like granuloma. So, important differential diagnosis for Crohn's disease is intestinal tuberculosis, because the affected area is also ileocecal region in both, and also you can see thickening of the bowel in both conditions. So how to differentiate these two entities? So ulcers in Crohn's disease will be longitudinal, and in tuberculosis it will be transverse or annular ulcers. And here you can see skip lesions and also cobblestone appearance, whereas tuberculosis it will be irregular distribution. Next, DD for ulcerative lesion is a neoplastic, in that the common one is malignant ulcers. So grossly malignant ulcers will be ulceroproliferative lesions having rolled up margin, and also the base will be indurated. So here you can see rolled up margin. And on microscopy, you can see atypical cells which are arranged in glandular or tubular pattern, and you can see hyperchromatic nucleus, atypical mitosis you can appreciate, and high NC ratio also you can see. So to summarize, ulcerated lesions can be classified as neoplastic and non-neoplastic ulcers. And when you are assessing ulcerated lesion, certain characteristics like morphology of the ulcers, whether the ulcers are circular, oval, longitudinal, or whether it is transverse or irregular, and also in addition size, distribution, depth, and also multiplicity also you should assess. Thank you.